Today I am reviewing the Legacy study published by Riyad Salem and colleagues in Hepatology in 2021. Legacy was a multicenter retrospective study of Y90 glass microspheres for solitary unresectable HCC. It included 162 patients treated at 3 U.S. academic medical centers between 2014 and 2017. It was an especially influential study because it served as the pivotal evidence supporting the FDA premarket approval for TheraSphere, specifically for the local tumor control in patients with solitary unresectable HCC smaller than 8 centimeters. The central question was straightforward. Can selective ablative dose Y90 produce a high and durable local response in patients who are not candidates for resection or thermal ablation? The clinical niche here is important. Patients with solitary HCC may be candidates for resection, transplantation, or ablation, but many are not eligible due to tumor size, difficult location, impaired liver reserve, portal hypertension, or proximity to structures that make thermal ablation unsafe. Historically, Y90 radioembolization was often considered a treatment for more advanced or multifocal disease. Radiation segmentectomy changed that concept by using selective arterial delivery to treat a small liver volume with an ablative radiation dose. The goal is not simply tumor control. It is to achieve a level of local response that resembles an ablative therapy while preserving uninvolved liver and maintaining future options such as transplant or resection. Before Legacy, however, the evidence base lacked FDA-agreed response endpoints. Blinded independent reviewers were required, and systematic duration of response data was also needed to be obtained. Legacy was a multi-center single-arm retrospective study using consecutive eligible patients from 3 academic centers. Eligibility was selective. Patients had to have a solitary HCC up to 8 centimeters, Child-Pugh A liver function, ECOG performance status of 0 or 1, and no prior liver transplantation or resection. Additionally, no prior local, regional, or systemic therapies were allowed, and the tumors could not have macrovascular evasion, and there needed to be no extrahepatic disease. In the end, the median tumor size ended up being 2.7 centimeters. So this was largely an early-stage, liver-limited population rather than the typically advanced HCC cohort from previous trials. One nuance is that the BCLCC designation was seen in about 40% of patients. These were classified as such because of ECOG performance status being equal to 1, rather than vascular invasion or metastatic disease. That distinction matters when interpreting the favorable outcomes. The study's major methodological strength was the blinded independent central review utilizing localized mRECIST as the primary response criterion. Localized mRECIST assessed the treated territory, which is the appropriate method for evaluating local tumor control after a localized treatment such as radioembolization. In the end, most treatments were selective and nearly 59% were classified as radiation segmentectomy. The median absorbed dose to the treated liver volume was 410 gray. The response results are the core of the paper. Utilizing localized mRECIST, the best objective response rate was 88.3%. Importantly, there were no local progressors by blinded independent central review within the treated territories. The 2 FDA agreed upon co-primary endpoints were both met. The first required the lower bound of the confidence interval for the confirmed objective response rate to exceed 40%, which it did very comfortably. The second required at least 60% of confirmed responders to maintain a response for at least 6 months or longer. Again, that was also met. 76.1% of confirmed responders had a duration of response greater than or at least 6 months. 15.1 months was the mean duration of response. The median duration of response among confirmed localized mRECIST responders was 11.8 months. Compared to other such studies that traditionally have used RECIST 1.1, for a devascularization procedure such as radioembolization, the mRECIST is more appropriate. The survival and disease control results were also impressive, although they should be interpreted in the context of a selected patient population with preserved liver function and solitary tumors. At 24 months, overall survival was 94.8%, and at 36 months, it was 86.6%. Utilizing localized mRECIST, at 24 months, there was no local progressions, and the 24-month progression-free survival rate was about 94%. The transplant and resection data are particularly relevant. 45 patients ultimately underwent transplantation or resection following Y90 radioembolization. Their 24-month overall survival was 100%, and their 36-month survival was 92.8%. This study also showed that there was preservation of function after the procedure. Among patients with available follow-up data, ECOG performance status was maintained or improved in 90% of patients at 12 months and about 82% of patients at 24 months. The most important interpretation is that Legacy established radiation segmentectomy as a credible ablative intent local therapy for selected solitary HCC. The absence of local progression by central review is incredibly notable. However, this refers specifically to progression in the treated territory. It should not be interpreted as the absence of all intrahepatic, out-of-field, or extrahepatic progression. Another major theme of this study is dose. The 410 gray treatment dose value seen in Legacy was using the unicompartmental dose and not the tumor dose. Legacy itself was not a formal tumor dose response study, so while it does establish a rigid tumor dose threshold, it does not show optimization. Still, it supports the broader principle that segmental high-dose treatment can achieve durable tumor control while limiting radiation exposure to the uninvolved liver. Subsequent pathology and dosimetry literature has further strengthened the rationale for ablative absorbed dose targets. The comparison with thermal ablation and TACE is clinically intuitive, but obviously it is not randomized. Legacy suggests outcomes that are comparable to other ablative local therapies while extending treatments to tumors that may be too large, too central, or too high risk for percutaneous approaches. This does not prove superiority over TACE, however, other studies have been undertaken to address that topic. Its limitations remain important. This was a retrospective, single-arm study, although it was conducted at multiple high-volume academic centers, and it is enriched for patients with preserved liver function and favorable disease biology. I think Legacy supports 4 actionable conclusions that may change practice. First, radiation segmentectomy should be considered for early solitary HCC when resection or ablation is unsuitable because of location, size, access, or other safety considerations. The FDA indication supported by Legacy is specifically for solitary, unresectable HCC smaller than 8 centimeters in patients with preserved liver function and liver-only disease. Secondly, treatment planning should be done with a dose-conscious mindset. The point is not to just simply administer any amount of Y90, it is to be selectively treating the smallest appropriate liver volume and safely deliver an ablative absorbed dose. In this study, a target around 400 gray is a practical benchmark for which supporting literature can start from. But obviously, this should be individualized to anatomy, target volume, liver reserve, and normal liver tolerance. Third, radiation segmentectomy is a strong bridge to transplant or bridge to resection option. The study does not prove that it improves post-transplant survival, but durable local control and maintenance of Milan criteria inclusion support its use during a transplant waiting period. Fourth, response assessment should emphasize tumor viability rather than lesion size alone. In practice, that means using localized MRECIST or LIRAD's treatment response criteria. RECIST 1.1 alone can substantially underestimate the biological effect of radioembolization. To summarize, Legacy was a pivotal multicenter retrospective study of 162 consecutive patients with solitary unresectable HCC treated with Y90 glass microspheres. Its key findings were an 88.3% best objective response rate by localized MRECIST criteria, a 72.2% confirmed response rate, and most importantly, no local progressors by blinded independent central review. This study provided the regulatory grade evidence supporting FDA approval for radioembolization for solitary unresectable HCC under 8 centimeters. The practical takeaway is that selective ablative intent Y90 should be viewed as a potentially curative local therapy for carefully selected patients, not simply as a palliative local regional therapy. Its strongest applications are solitary tumors unsuitable for ablation or resection, and patients who need durable control while waiting transplant or reassessment for surgery. Thank you.